So I had the pleasure of presenting data on REGN5458, which is a bispecific antibody that simultaneously binds BCMA on multiple myeloma cells and CD3 on T cells as part of a phase 1 dose escalation study. The part of the study that I was presenting data on was actually the first of 2 parts. My part, or the part we were reporting on at the meeting, was dose escalation, where our main objective was to assess the safety and tolerability, to determine if there was a maximally tolerated dose, or MTD, and also to determine the dose that we were going to use for the second part of the study, which is actually ongoing now, but which we didn't report on, which is a phase 2 expansion study, where the dose that we doses that we select from the first part are used in larger treatment groups to further look at the effectiveness of that dose. So in the abstract that we presented, there were 73 patients with relapsed myeloma. And to be eligible, the patients had to have active myeloma according to the International Myeloma Working Group, and had to have been previously treated with at least 3 lines of therapy that included a proteasome inhibitor, and be refractory to a proteasome inhibitor, an immunomodulatory drug, and an anti-CD38 antibody. Or they could have had a regimen in which they were double refractory to a proteasome and an IMiD, and then subsequently progress on or soon after a regimen with a CD38 antibody. These 73 patients were enrolled in cohorts using escalating doses of REGN5458. We started at a very low dose. The first cohort, it was just 3 milligrams intravenously, weekly initially, and then after the first 16 weeks, we spaced out the dosing to every 2 weeks, and patients could be treated on an ongoing basis at that schedule after that. And we escalated from 3 milligrams at the lowest dose all the way up to 800 milligrams at the highest dosing cohort. When patients were dosed, in the first 2 weeks, we used lower doses to try and minimize the risk of a specific side effect called cytokine release syndrome. And then after starting at week 3, we would treat them at the dose level that they were assigned to, the full dose for that cohort, and continue that weekly through week 16, and then adjust the schedules every 2 weeks after that. We really saw an excellent safety profile overall. We never hit a maximally tolerated dose at any level. There were dose-limiting toxicities seen in just 2 patients out of the 73, one at the 24 milligram cohort and one at the 96 milligram cohort. So patients treated even at higher doses than that didn't show dose-limiting toxicity. We saw both hematologic and non-hematologic toxicity. The most common hematologic toxicity was anemia in about a third of patients, and neutropenia was less common than that. It was 23% of patients. The non-hematologic toxicities were actually quite mild. They were almost all grade 1 and 2. The most common was fatigue, which occurred in just over 40% of patients. There were infections seen on the trial, and respiratory infections were somewhat common. There were a total of 5 deaths on the trial, all of which were infections. In each case, though, the treating physician did not feel it was related to REGN5458, and in none of those 5 cases were the patients neutropenic at the time the infection started. We drilled down on that one side effect that I mentioned before, cytokine release. And cytokine release syndrome was only seen in 38% of the patients on this trial, which is quite a bit lower than what's being reported in the with other bispecific antibodies in myeloma, and also with the BCMA targeted CAR T cells. The CRS rate in those other studies is usually about twice as high. Almost all of the cytokine release events that we saw in this study occurred in the first 2 weeks, usually within 24 hours of one of the step-up doses. And it was, in most cases, grade 1 and only grade 2 in 3 cases. And there were no grade 3 or higher cases of CRS. There were some patients who needed tocilizumab or steroids to manage the cytokine release, but it was a minority of patients. The other side effect that we provided some information about, or that we were really looking for, was ICANS events, or immune effector cell associated neurotoxicity events, ICANS. And those were seen in only 12% of patients on this study, usually in the context of cytokine release. Of the 9 total events seen, 6 of them were grade 1 and 3 of them were grade 2, and there were no grade 3 or higher suspected ICANS events. So we were quite happy overall with the safety and toxicity profile that we saw in this dose escalation portion. We were also quite happy with the efficacy that we saw. In a phase 1 dose escalation study where a lot of the patients are being treated at very low dose levels, you don't necessarily expect a high response rate. But in fact, we saw a 51% overall response rate on the study, including responses at all dose levels tested. One of the longest responses on the study, which was over 19 months and still ongoing at the time of the data cutoff, happened in one of the first patients treated at the lowest dosing level. If we focus in on the patients who were treated at the higher dose levels, the 200 to 800 milligram dose levels, the response rate in that group was actually 75%, which is about twice as high as the best non-cellular therapy options for this same patient space when you're looking at the FDA-approved options. The majority, over 80% of the responses on this trial were high-quality responses, meaning a very good partial response or better. There were actually some patients that achieved a complete response, and we had minimal residual disease assessment data on 10 patients on this study, and of those 10, 4 of them became MRD negative. So those are really impressively deep responses. The duration of response was not reached on this study. We're still waiting to see what that is, but the modeling shows that there's over a 90% likelihood that responders will still be progression-free 8 months after the start of therapy. So early responses, deep responses, and durable responses. So we were quite happy to see all of those things, as well as the safety profile. When we put it all together, we feel that this is promising, and we feel that this definitely supports the idea of developing Regeneron 5458 as monotherapy for patients with heavily pretreated relapsed myeloma. And we also look forward to a future umbrella study where we start looking into how best to combine it with other standard myeloma drugs, as is often done with new myeloma therapies.